Hi, good evening, everybody. All those people who are here, all those people who are listening to us, all those people who are watching to us. Very good evening. I'm Dr. Himanshu Mathur from Jaipur Rehab. We are again here for our coming venture about the pressure plate or the plantar pressure analysis. So here we have with us Mr. Hriday Nakhate. I would like to give a brief introduction about him before we start with the topic of the day. Mr. Hriday Nakhate is the managing director and co-founder of Can Innovations Private Limited. He has completed his Bachelor's of Sciences in Business Administration from Northeastern University in Boston. He has been a part of physiotherapy, patient, I'm sorry, of physiotherapy for somewhere like 6 years and has developed a great appreciation for the physiotherapy space. Then eventually he had an idea of developing a pressure plate which could assess the plantar pressure and which could be helpful in a biomechanical analysis for plantar pressure analysis. So he has made it his mission to elevate the level of physiotherapy, podiatric, and diabetic care available to the general public. He has started this journey with launch of his first product, that is OHM 3000, a wireless portable plantar pressure system designed especially for the Indian practitioners. So I would not leave any stone unturned and don't would waste any much more time. I would like to hand over the session to Mr. Adair for foot posture and plantar pressure analysis using pressure plate system. The session
Sure.
is all yours, sir.
All right. Hi, everybody. Thank you very much, Dr. Himanshu. It's a pleasure being here. Today, I will be talking about the plantar pressure system and how it can be used effectively, clinically, as well as to help boost your your physiotherapy practice. And let me first, start by telling you a little bit about what you're going to expect today in today's meeting. So let me just. So I'd first want to introduce me and my team to you. I'd want to tell you a little bit about the plantar pressure analysis, the basics of it. I'd like to introduce you to my product, go over case studies, three case studies I have for you, and also discuss what we offer as a company. And I'll be trying to take any and all questions at the end of this. Yes. So as you can see, we're a 2-year-old startup based in the heart of Mumbai. We build technology-based solutions for health and wellness. As you can see, we're a very fun-loving team, and we've been working very hard at it for the last 2 years. A lot of work has gone in from every single person, and we finally ended up with the OM 3000. Now, my goal with the OM 3000 is to help elevate the level of physiotherapy, podiatry, and diabetic care available, as Dr. Himanshu mentioned. Um, as he was telling you, I've been a patient of physiotherapy for almost 6 years, having suffered an L4, L5 disc desiccation, a right knee meniscal tear, followed with a left knee dislocation. I've been in and out of physiotherapy and have learned my lesson many times around. And I've actually really, developed a very, very strong appreciation for the science. I've had some great physiotherapists along the way, and I've learned so much from them. And I wish to give back in my own way so that problems that happen to me wouldn't occur to anybody else. So as mentioned before, Can Innovations, we believe in educating both practitioner and the general public. We want to facilitate better diagnostic protocols. We want to aid in rehabilitation and also help improve health and fitness overall by the means of technology. So let me start off by telling you, 2 years ago when I came back from the US, I first wanted to study the market and understand what it is that physiotherapists suffer from in their practice, in their day-to-day practice, both clinically as well as business-wise. And here is a couple of data points that have come from a survey that we had done with over 100 physiotherapists across. So first things first, 29% mentioned that diagnostic inaccuracies was one of the problems that they suffered in their clinics. This often happens when you have big setups with a range of different physiotherapists with different levels, like junior BPTs to MPTs to senior experienced physiotherapists. Often diagnostic protocols change, and also the way they see the patient differs. So the other problem was 34% of them complained about Google doctors, and this is something that I think many physiotherapists have started facing in the recent times. Although in the last 10 to 20 years, Google has come up a lot. People ask any and all questions on Google, and they often get good answers to it. And now they know where to seek help first. But also, what has happened due to that is that patients have come in thinking that they have a 4-year degree, having read 2 articles about the kind of pain that they're having, and often it becomes a burden for physiotherapists to convince them about why they're choosing a certain treatment method and how effective it's going to be. 45% complained about credibility being an issue. Now, physiotherapy, as we all know, whoever's watching, physiotherapy has grown so much in the last 10 to 20 years. People like myself have grown, to appreciate the science. But there is a big population that is not aware about physiotherapy as a practice, as well as, understand. They don't understand the benefits at all. So 45% said that credibility is a bit of an issue, where patients still are finding it hard to trust what the physiotherapists are saying, especially first time patients who walk into the clinic. 65% complained about dropout rates, and 40% complained about motivating patients. Now, these go hand in hand. Often, patients, who come in, they eventually go through the pain relief stage of physiotherapy, and post pain relief, they often think that they're okay and they can forget about strength and conditioning, and that they believe that they don't need the physiotherapist anymore, or they don't see enough improvement to continue doing the sessions, and often those patients end up with more injuries, either recurrence or new injuries that pop up. Now, as I mentioned, that both motivating patients and dropout rates is difficult, because when results start plateauing, patients often drop out, and that's why we see 65% complaining about it. 18% of them complained about image of physiotherapy in conservative families. We saw this, across the board. Actually, oddly enough, we had first initially seen it only in low-income areas, but what we noticed is that it further also goes even to the upper class. We see that convincing families that physiotherapy is an important part of their recovery or rehab was difficult for certain individuals, especially women. Lastly, 75% complained about not having a way of objectively tracking recovery. Now, when we talk about objectively tracking recovery, right now most physiotherapists, just because the sheer volume that we have, volume of patients that you guys have, to not having the maybe not, some don't document, just surely because the number of problems that are there on a day-to-day basis, or the fast-paced environment that is there in the Indian setups, not many have a way of objectively tracking recovery, and a lot of them told us that they would like to see something in this space. So that actually led us to thinking as to what can we do to help solve all these problems, and that's how we ended up with the plantar pressure system. So plantar pressure analysis, for all those who don't know, is also known as pedobarography. It is the study of the pressure area that acts between the plantar surface of the foot and the supporting surface during static and dynamic activities. Now, when we talk about this, it's important to understand that the foot is basically acts as the foundation of the body. If something happens to the foot, if there is misalignment in the foot, you have problems that can go all the way up to the lower back, upper back as well, and you see misalignment get carried through. And it works vice versa as well. If you have an underlying injury, whether it is the knee, hip, or back, you're able to see the effect of that injury also in the plantar pressure. So it is important to understand that this tool is not only for the foot, but it tells you about what is going on with the rest of the body as well. So as we dive into plantar pressure analysis, I want to tell you a little bit about the tests that we conduct on our OM 3000. Now, we've coined it the step test, and that is mainly because we believe that in our effort to educate both patient and practitioner, we needed something that we could carry and market. So that is why we've called it the stride test evaluation for plantar pressure. It is a company coined name, but the tests that are there below are clinical methods that are used across the world. So I want to run you through the bipedal test first. As you can see in the video there, the bipedal test is basically to understand static pressure distribution when someone is standing. Then you have stabilometry, eyes open and eyes closed, and these two tests are basically to understand balance. So you can understand balance and you can understand fall risk. You then have foot posture, which is basically we take a picture of the ankle, where we understand whether your ankle is whether your heel is inverting or everting. Sorry about that. And we do it both while standing as well as in half squats. And half squats is mainly to mimic overpressure, something that, to understand how would your heel and ankle behave when you were walking or doing any dynamic activity. Now we also have a dynamic test as well, where we understand your walking pattern and your gait, basically your gait pattern. And we have many metrics which help you analyze the patient as well as see whether your treatment protocols have worked. Then we also have the custom test available, where you can do single leg balance, tandem balance, single leg squats, and also lunges. So all of these are actually, the custom test is something where you usually use COP to track movements or track your static balance. And this is to challenge the patient even more, or to develop your own protocols as a practitioner to evaluate improvement over time. So this is to add versatility to the product, and to also allow you to use it with a variety of different patients. Now, before I get into what kind of case studies we'll be doing today, I want to mention that this device and this analysis is useful for all kinds of patients, whether it is orthopedic, whether it is sports injury related, whether it is neuro cases, geriatric cases, even women's health, where you have pregnant women, you want to analyze fall risk. So it is applicable to a whole range of patients that come in. So, without any delay, I'd want to go to the reports. I think this is something that will excite some of you, and where we can go over a couple of cases. I'm going to go over the plantar fasciitis case. I'm going to go over an orthopedic case, and I'm going to go over a limb length discrepancy case that we've done. So, I want to point out here that when I cover the three cases, I'm going to be looking at a couple of different things in each case. So, don't mind me if I don't explain each and every data point in one case. I will try to cover it in the next one. So,
Is everything okay?
yes, yes, everything is fine. Just trying to share my screen. Is my screen visible, Doctor? Right.
Yes, it's
Right.
visible.
Great. So this is. Let me tell you a little bit about the case. Right. This is a 28 to 29-year-old woman. She was. She spends most of her time, standing during the day. She'd called into the clinic complaining about an immense amount of pain in the soles of her feet when she woke up in the morning. She also complained about a extremely excruciating pain in the right heel specifically. She mentioned that as the morning progressed, you know, the pain would slowly go away, and she would feel fine until the next morning. However, in the recent past, she'd had a couple of days when the pain, carried forward into the afternoon, and she was unable to go to work. So when she came into the clinic, we got her plantar pressure analysis done, and here are the findings. So just before I tell you about each of the different data points that you can look at in this case, I want to tell you that this patient was unaffected, or rather not in pain, when we did the analysis, because this was in the later afternoon. So I will show you how you can relate the information to the kind of pain that she was experiencing in the morning. So as you can see the hind foot in both cases carries a lot of pressure, as you can see in the markings that I've made. You see that the peculiar area of the right heel has an extremely high amount of pressure that comes in, and that is the area that she was complaining about. So as you can see the color scale here on the right, uh, it goes from white to pink. White indicating extremely low pressures, or blue indicating extremely low pressures, to pink, or fuchsia, which is basically indicating high pressure. Now this is always relative, whether you have someone with a BMI of 20, or a BMI of 15, or a BMI of 30. The color scale will always show you the range between high and low pressure zones. The numbers here on the right are very, very important. Now, the system that we did this on, which is our Ohm 3000, is a calibrated system, which means that the data that you're looking at is in kilopascals. So you're looking at absolute pressure in this case. So in this case, we're looking at So as we see that she puts a maximum pressure of more than 140, so almost 144 kilopascals, as you can see on the right heel, and that is a cause of concern. We look at the arch index. Now, arch index tells you whether it is a flat foot or a normal arch or a high arch, and you can see that according to the norms, 0.21 to 0.25, the left is considered normal, whereas the right is considered flat. We then further go on to understand average pressure between left and right, and you can see in this case that there is no major difference between left and right, and you can also see that in the weight distribution percentage, which is 47.65 to 52.35 from left to right. So there is not much difference in terms of body weight, in terms of pressure or body weight being carried on between left and right, and that is good. Now, we also look at the numbers here, of the weight distribution between, in the left foot, between the forefoot and the hind foot. And what you can see here is that only 30% of the weight of the left foot is distributed on the forefoot, whereas 70% is on the hind foot. In normal cases, the global averages indicate 40% of the weight should be on the forefoot versus 60% on the hind foot. Now, when we look at the right, it's actually worse off. You see that there is 21 on the forefoot, whereas almost 80% or 79% on the right foot. And you can see why that problem area of the right heel is coming into picture, because most of her weight is on the heel itself. We then have some numbers here: foot length, foot width, hind foot width. Now, the real question here is, why is this important? And the reason is that, as physiotherapists, you work incredibly hard on your patients, and when someone goes out and buys a pair of shoes that don't fit them well, often all the work that you've done slowly gets undone, and it causes more injuries later on in the future. And that is why we've given this information. You can also use this information to prescribe insoles as well, remembering the fact that this is not a 3D scan, it is a plantar pressure system. So it is talking about contact area and contact length and contact width. So it's an important consideration when you're looking at the data. Then we look at foot area. Now, foot area is something I will cover in the later on case study, just to explain how you can use it for different cases. We then have the case of bipedal, and we talk about the foot posture over here, trying to understand whether there is inversion and eversion at the ankle. Unfortunately, the clinic was incredibly small and had poor lighting, which is why it's such a dark image. But you can still see, if I zoom in, right? Sorry about that. You can still see that there is a little bit of eversion that is happening. And when we compare it to overpressure, you can see that it has further deteriorated when she's in overpressure stance. See, now this is a test that we often say that physios can often look at it visually and see what is going on with the patient at the ankle level. However, when you combine this with the information that's in the dynamic, it becomes a powerful tool to talk to the patient, to educate the patient, and also make sure that they go for the right kind of treatment. Whether if the answer there is insoles, or if the answer is taping, or if the answer is exercises, often patients get inclined to believe it more and also take it more seriously. Now we come to stabilometry. Stabilometry is one of my favorite tests to talk about. And you know why? It's because it is a balance assessment. It's so amazing to see that there is a value that I can assign to balance. And clinically, the two most important values that we talk about is sway distance and sway velocity. This is basically talking about the sway distance, basically talks about the amount your COP has moved while you're standing for a duration of 20 to 25 seconds. And the sway velocity is basically at the speed at which it is moved. These numbers help you indicate whether there is a chance of fall risk. Often you will be comparing this number to the eyes closed stabilometry values to see an increase. The other numbers here are left foot weight distribution, right foot weight distribution, to further tell you how the weight is being distributed. Weight distribution between left and right, which is useful when you're dealing with patients with orthopedic or sports injuries, or with neuro cases as well, where you have somebody leaning more on one side than the other. The other values that are again very useful clinically are left foot anterior posterior, right foot anterior posterior deviation, and maximum lateral deviation. It helps you understand a little bit about what kind of muscle groups are at play, and how weak or strong the different muscle groups are in maintaining your balance. The last important measure is the central pressure area, and this is something that I highly recommend for researchers. So when you're trying to understand central pressure area, it's very important to understand the algorithm that has gone behind writing it. So there are four globally accepted algorithms, and we use the polygonal pattern to do the central pressure area. And once understood, it can be a very good effective research tool as well. Now, when I'm comparing, for this particular case, when I was comparing sway distance and sway velocity, I want you to pay attention to the numbers. You're looking at 164 in sway distance and 8.23 millimeters per second in velocity. And when we compare it to eyes closed, we see that it has increased. The sway velocity is increased to 22.48, and the sway distance is increased to 449.56. Now, according to global norms, you're expecting an increase of 20 to 50% in sway velocity. So 20, beyond 20 to 50%, it means that this person is at a risk of fall. Now, in this case, it is almost 300%, which is a definite indication that this person needs balance training and someone needs to intervene. Moving on, we now look at the dynamic. Now, as mentioned by Dr. Ashutosh as well, that it is very, very, very important, by Dr. Himanshu as well, is very, very important to understand um, what is going on when a patient walks, and how the biomechanical analysis is done. So it contributes a lot into the kind of diagnosis and treatment plan that you come up with. Now, often you don't have access to any of these technologies when it comes to your clinical practice, and that is why we're here with the 3000. So I want to point out with the plantar fasciitis case a couple of things that you would be looking at when you're looking at any case. So first things first, you notice that the pressure, there's high pressure through and through, and the black line, which is the COP line, starts off at the heel, which starts off medially and then ends up going through through the forefoot into through the big toe and out. Now that often is considered to be normal. However, the line is relatively very medial in nature and could indicate that this person is pronating while walking. It is the same case when it comes to the right. However, in the right, there is more abnormality. As you can see, there is high pressure zones that you can see mainly in the hind foot. And that is something that doesn't transfer over to the forefoot as normally. We also notice that the line, or the COP line, starts quite late in comparison to the left. And that means that the heel strike itself is not normal. So these help you understand the abnormality of this case. Now you can see that the black line goes through the forefoot. However, there is an abnormal toe off as well, whereas the line should be carrying forward from the big toe. However, there is an abnormal push off that happens, and the patient is suffering because of this particular gait pattern. We further see that in the dynamic graphs, the PTT, as I would say. Now the graphs indicate left, right, and both feet, and the green lines indicate the total pressures for the foot, the entire foot. The red lines indicate total pressure for the hind foot. The blue lines indicate the total pressure for the forefoot. Now, in both these cases, we have to look at two peaks. We look at the hind foot peak, which is called what we call peak one, and the second peak, which is peak two. In all cases, in normal gait pattern, you should be seeing peak two being greater than peak one. However, that is not the case in this. So we also notice that the amount of time of contact for both the heels is extraordinarily high, and we notice that this is one of the reasons why we can say that this gait is also abnormal. We also see the same for the forefoot contact, and we can make we when we looked at the patient, and we also remember that when you're looking at plantar pressure analysis, you also have to look at the patient. You have to evaluate what is going on biomechanically as well, or from head to toe. And we noticed the patient was slapping his foot, and these results are indicative of that as well. Slapping her foot. Apologies for that. Now, coming to the kind of data that you can get and how you can use it. Uh, I think when you look in dynamic, the pressure transfer tracker allows you to see a whole range of 30 values that comes in that can help you understand a plethora of different conditions that go on. Whether you talk about knee pain, or you talk about neuro cases, or you talk about meniscal tear surgery, post surgery rehab, everything. All these values can contribute in a better assessment and a better method of monitoring. So we look at stance time here, and we see that almost one, you see, you're looking at the difference between left and right. Now, in most cases where you have orthopedic cases of where you're dealing with someone with a meniscal tear, you would see a difference in stance time where the affected limb would make less contact with the ground in terms of time. And we also see that in cases that are like hemiplegic stroke patients, and that's also what you'd be also be able to see in stance time differences as well. Now, in diabetic cases, you often will also see a change in the stance time, but it'll be reverse, where you would see an increased amount of time being spent on the foot that is affected with diabetic neuropathy further. So the other numbers that you're looking at is contact area, and contact area is again a very very valuable input for especially neuro patients, even sports patients as well, but neuro patients especially. Cases like cerebral palsy, hemiplegia, you would be looking as a physiotherapist to also help improve the contact as someone goes through their rehab, and this number becomes very very useful. Something that is not easily possible right now on a day-to-day measure. And most neurophysios, if any of you are watching this, you would understand that your rehab programs with your patients are long term. They have small improvements every day, and it becomes difficult for patients to stay motivated at times. So therefore these numbers are very very vital in showing the effectiveness of your treatment. We then have peak pressure, very, very useful for diabetic cases and sports cases to understand the amount of maximum pressure, region of maximum pressure that is being applied on the foot. When you look at the heat map, you're also able to isolate these areas which are in high, in bright pink. And for diabetics, you're able to use those to actually also prescribe insoles for them. This is also true of any case where pressure is exceeding, where you see corns and calluses. You would often see the same areas be lit up in bright pink when you would come across some cases. Now we have average pressure in KPA, and average pressure is something that tells you the differences between left limb and right limb. Again, this would be different for you would be able to see this as a deciding point for cases that are suffering from orthopedic injuries, or even neuro cases like hemiplegia and stroke patients as well, where affected and unaffected would have different ones. You then have values of COP deviation and excursion index, which indicate dynamic stability and help you assess the person's dynamic balance. Foot progression angle tells you about toe in and toe out, which I'll cover in a later case. You then have loading slope, which talks about basically the rate at which the pressure increases and decreases. Very useful in analyzing for patients who are, suffering when they walk, when they experience a lot of pain, or even sports patients who want to understand a little bit more about the way they load. You then have a lot of this data again being broken apart into heel, midfoot, forefoot, hallux and toes, etc. These areas are the reason why we've given a bifurcation here. It tells you a lot about how different parts of the foot are behaving during the gait cycle, and it can tell you about it can help you isolate the problems. And tell you, one problem versus another. For example, how a heel spur would behave versus plantar fasciitis. You can actually use the heel information to indicate that. So I'm going to now move on to the next case study, which is a case study on uh, for a meniscus tear patient. I'm again going to share the screen. Right. So I want to tell you a little bit about this patient. This patient is 26, had a BMI of about 31, had a right knee meniscal tear about a month ago when we had taken this test. And when he started receiving rehab only a week ago, and he was still in pain. So it's important to understand this, because when we look at the data, we're going to understand what to look at and some things to ignore as well, and what to be looking at or looking out for as the patient's rehab program progresses. So a couple of things, main differences you can see clearly is between weight distribution between left and right. Now you're seeing 71% to 28% from left to right, and I'm sure that all of you are thinking that, okay, the right is the one that is affected, which is true. The right is where the right knee meniscal tear had happened, and you can see that the person is unknowingly, or as well as knowingly shifting his body weight onto the left. Even after we've asked them to stand in anatomical position, the body is still loading on the left because of the injury on the right. We also notice that in terms of the difference in average pressure, and you can see that that goes from 54 kilopascals to 23 kilopascals from left to right. We Now, when you look at this patient, and you must be thinking that 71% is a lot. It is a lot of load to take on one limb alone, and this can often cause an injury in the future on the left foot. This is something that is common. It is also part of my story. It is something that happened to me, where I had a right knee meniscal tear but followed with a left knee dislocation. Only prior to the dislocation did I realize that I was loading 70% on my left, and it resulted in a left knee injury as well. So this is something that I would be concerned about had this been probably a month, or a month into recovery. We now look further into the balance, and you notice that the balance is 22.28, and you notice that the person is loading 75% on the left versus 25% on the right. And even when they have their eyes closed, they're loading it goes up to 41, which is a 100% increase. And you also see the distribution still being 70, 65, 35, which is something that tells you that the recovery has not happened. And since we know that the patient has only been in recovery for a week, we can understand these numbers. Now, this is something that you would also be looking out to see as an improvement over time, and you can use these numbers to monitor patient progress as they go through your rehab program. So let's talk about dynamic in this case. Now, in dynamic, again, I'm looking at this particular patient, and I see that when they're walking, they have a relatively normal gait pattern that starts off from the heel quite normally and goes through the big toe. However, I want to point out one area of concern is that there is the line might be a little medial in nature, and the person might have a little bit of instability, and we can see that. Um, this is obviously because of the injury that they have sustained. So we look at the pressure transfer tracker, and just prior to the pressure transfer tracker, I do want to point out the differences between left and right. So we look at the stance time, and we see that there's a significant difference between left and right, between 0.87 and 0.63. And we notice that this is because of the affected versus the unaffected limb that you're seeing, the right being affected and the left being unaffected. The average pressure, however, is similar in many cases. In many cases that have meniscal tears or ACL injuries, or are going through who've had a knee replacement and are going through rehab. All of those will, when we look at this entire thing, we can also see a difference in average pressure between left and right. We then have a number for progression angle, which is the degree of toe in and toe out. It tells you about whether the gait is efficient or inefficient. In this case, it falls under the norms of -3 degree, which is 3 degree inward, to 20 degree outward. This actually, in case you have someone who comes in with knee pain, and you're trying to help them solve the problem, not just treat the pain. Uh, One of the resultants could be an inefficient gait, where they have too much degree of toe out or too much of degree of toe in. And once you actually get these numbers, you can tape and redo the test, and you can see the difference, whether it's altered, firstly their gait pattern, and secondly their pain. And often this can actually result in a good treatment plan that can help them long term to reduce pain without any without constant intervention. So now, looking at the dynamic report, this is the left is an indication of a relatively normal gait pattern, where you see peak one being less than peak two, and this is something that we are able to, this is something that we consider normal. However, the right, although following the same guidelines, is truncated, as you can see. They work on two different, this is because of the amount of contact time that each foot has with the mat, and you can see that the right is affected because of the pain. So, in short, this is the case study with orthopedic cases. It is very important to use information in dynamic, in stabilometry, and bipedal to make sure that the patient has recovered completely. So, often in most cases, patients end up leaving midway because they start stop seeing major recovery after the pain relief stage. And these information points not only keep them to their rehab program and get them coming into your clinic to complete their exercises and complete your treatment that you have prescribed to them, but also help them but also help make sure that they don't end up having a recurrence of the same injury, or have another injury on the other limb because of this. So this is how you can use this effectively in your practices to prevent people from having serious complications in the future. This information is also true for osteoarthritis and rheumatoid arthritis cases as well. You will be able to see differences between affected and unaffected limbs, and also track progression of disease and improvement if based on your treatment plan. Now, very quickly, I'm going to go through the last case study, and I'm going to just share the screen one last time. And we'll talk about LLD. Now, this patient is 44. She came in with a limb length discrepancy that she's had since birth. She had recently, as in a couple of years ago, she'd had a hip replacement done, a total hip replacement done due to avascular necrosis that had happened. Now, this is something that we talk about being quite. It was quite a severe case that this person had been in pain for almost 44 years, and she'd been in physiotherapy for 22, and she'd recently got herself a pair of custom shoes made, and she was unsure whether this was something that was effective or not. So we said, okay, why not try it out? So very quickly, let's go over the numbers here. You see that there is a loading of 75% on the left and 25% on the right. Now, the left is the shorter limb, and the right is the normal or the longer limb. Let's call it that. We then have the pressures, and we can see that this person has a peculiar high pressure zone in both left and right when it comes to in the midfoot, which is something that is very abnormal. You don't see this in normal cases. Normally, you would see it in the midfoot or the in the forefoot or the hindfoot, not in the midfoot, when especially when standing. And this actually resurfaces in dynamic again, and I will show you that when I come to it. We also notice the average pressure, and we keep that in mind. This person was not diabetic, so we were not very concerned about the maximum pressure, but you can see that there is a maximum pressure of almost 131 in that midfoot region, as compared to only 54 on the right. We look at the weight distribution for this particular case, and we see that 76% is on the hindfoot of the left and 81% is on the hindfoot of the right. This could, in cases that, forgetting about this case and talking about any case that has lower back pain, you would also see a similar pattern in those cases as well. We now talk about stabilometry, and this is how you would see the data on the map, on the app. And you can see that there is a big black scribble here. That is an indication of how much your central pressure has moved when, when you're going through the test, when she was going through the test. And you can see that the black scribble is quite big, and it's completely leaning towards the shorter limb. We looked at the information, and again, I'm going to keep it very simple and only compare the two major ones here, which is the sway velocity and the sway distance. And you can see that the sway velocity is 15.31 millimeters per second. So we asked her to put on the shoes, and then we wanted to see the difference. And what we notice here is we see that the pressure and the COP COP line has actually decreased. The scribble has become smaller. Does that mean she's better balanced? So we see the sway velocity for that, and we see that there is a decrease in sway velocity, which means that there is better balance achieved now with her footwear on. Now we also look at another number here. So this is barefoot. We see that almost 79% is on the left while she was carrying out the test. We notice here that it's reduced to 70%. And obviously, this is a person who's had limb length discrepancy for almost for a 44 years since birth. And you can understand that, reappropriating pressure will take its time. Now, we go into, foot posture. And for this particular case study, the foot posture is not applicable simply because this person does not have this person cannot keep their knees straight when they are standing or getting into half squats. Therefore, this test cannot be used to evaluate this patient. Now we look at the dynamic, and we see that in the dynamic, again, there are these high pressure zones in the midfoot that we saw earlier. But we also notice that in the left, we see the black line, the COP line start off normally, but then end up going through the third toe, whereas it should be going through the first or the second toe. In the right, however, although the line goes through the second toe, it starts off very laterally and still has a relatively abnormal pattern. The stance time is significantly different between each other. You can see 0.71 to 0.82, and this is an understanding that the limb is different. However, since she is in motion, the average pressure has become better between left and right because she's carrying the weight on one foot at a time. But you can see that the shorter limb still receives a significantly more amount of pressure on the left, which is the shorter limb, versus the right. We also have foot progression angle. Now, I want you to notice the numbers; they're normal as of now. So when we asked her to, when we look at the data here again in the graphs, we notice that for the left, which is the shorter limb, we see this abnormal peak that comes in here. There's an abnormal curve that happens over here, and this is that peak 3, or what we can call the midfoot region, that is activated, which is relatively very abnormal. The right, however, follows a normal gait pattern and can be considered to be normal in its way. Now we asked her to put on her footwear, and we noticed that first things first, the COP line is going a little bit more lateral in nature. She looks to be better balanced, and the COP line is transferring to what we can assume to be her big toe and second toe. However, her right, now I want to make a very important point here. The left was adjusted for the limb length discrepancy, but the right was not adjusted with the change in with the reference of the change to the left. So therefore, the right being prefabricated has caused a disruption in the gait pattern. We notice that the stance time has equalized, which means that you can possibly say that she could be better balanced, in a way, but we cannot be certain because of that. We also see the average pressure hasn't changed much between left and right. We do notice the foot progression angle of the left has increased. However, a complex case like this is a judgment call, and for the physiotherapist who was in charge, she did not think this was a cause of an area of worry. Now, when we look at the gait patterns here in the PTT again, we noticed that the third, the what we were talking about, the midfoot region, is no longer causing a problem. This is indicating a more normal, gait pattern. However, the right, as I mentioned earlier, since it was a prefabricated shoe and was not adjusted in reference to the left, has caused more damage than it has done good. Therefore, one of the recommendations, after observing and after spending time, one of the recommendations that the physio told her was to get the right altered as well, and she took this information to the person to get the amendments done. So I'm going to stop with the case studies here. I hope this was interesting for you. I will now move on back to the presentation. All right. So now I want to take the second to basically tell you a little bit about the Ohm 3000. Now, the Ohm 3000 is our product. It is a wireless portable plantar pressure system, the first of its kind, made in India, designed and developed for the Indian physiotherapist. So we studied a lot of physiotherapy practices to come up with this device. It is truly wireless. It works. It has a so first things first. It runs and operates with a 10.8-inch high-resolution Android display. It basically connects to the mat wirelessly via hotspot or via Wi-Fi. It has the mat has an inbuilt battery life of 5 to 6 hours, and we also provide an external power supply that can make it last for about 24 hours. One of the patterns that is followed in India, a lot of physiotherapy practices, that a lot of them do events. A lot of you physiotherapists do events with corporates, with sports patients, with many others, where you need to go outside your clinic, and this becomes a very useful tool for that because we've built that capability into the mat itself. We then have what I would want to mention is 2916 sensors of a sensor density of 2 sensors per centimeter square. Instant report generation. It is a high resolution display. It's a high resolution scan where you can get about a resolution of 2 sensors per centimeter squared. This is very high for clinical purposes and can also cater to research purposes as well. We also the mat is capable of also being carried. We have provided a carry bag with it, which can be carried anywhere you go. And what we've also done to it is that we've built in an instant report generation capability onto the tablet itself, where you're able to generate a report instantly after doing the evaluation and share it with your patient, whether via email or even you can print it out if you're in your clinic. The other thing we've also done is that we've understood that many setups have have multiple physios working under them, and we created multiple user IDs for them to log in, where they can have their patients review and compare, and use that login basically to review, compare, and monitor results over time. You can actually use it to also log in into your PC, and from your PC screen or from your desktop screen, you're able to actually review the data while someone else is using the mat for and conducting a test on their patient. The Ezra now. So I want to introduce you to Ezra. Ezra is the digital assistant. Basically, it is the app behind that powers the mat. It is the application that not only allows you to register patients, but also record information like demographics, history, examination details, evaluation, and also cloud it for you to review it later on any device that you choose. Now, one of the things that a lot of physios mentioned to me was that they wanted to make sure that this device was would be adopted by anybody working there. Now, often when you come across plantar pressure systems or you come across gait labs, they're very complex to use because they're built for research. They're built only for research. Now, we've built this with the idea that it can be clinical as well as for research purposes, and that is why we built it with the app. To make it super easy. It's on Android. Everyone is familiar with it already, and you can see how easy to use it is when you do a test. Now, this is a bipedal test. It has an animation to show you the patient or what to do, and you can start the test. And within a few seconds, sorry, within a few seconds, you have the instant visualization of the data where you're able to see whether the data is good enough and you want to carry on further or you want to retry the test. In the evaluation, you get access to all the different data metrics that you saw earlier in the case studies that we discussed today. This is your online portal. You can sign in, you can compare results of the same patient or different patients over time and track recovery as well. Now, coming to what we do as a company. This is an important part of what my mission is. It's not only enough to build a good product and leave it there. It's important to make sure that people are empowered and you're seeing change throughout the chain. So we've introduced the Plantar Pro program, and we strongly believe that your success as a practitioner is our success as a business making a device like this. So the reason why I introduced the Plantar Pro program before I talk about the benefits is that uh, I want to tell you that this is not something. If you decide to take on a device like ours, this is not something that we leave you hanging. We make sure everything from training to marketing to everything is something that is to all these other different facets of business and practice are taken care of, and we work together in making sure we can drive value to your patients. Now, in the Plantar Pro program, you get registered as one of our partners, and we list you on the website. We do nationwide social media campaigns as well as local social media campaigns, um, focusing on trying to get educated patients into your clinic. This is to help improve business and also make patients aware of what exists out there and make them aware of how they can get a solution for their pain. We also do many different kinds of events in different cities, which I'll show you a few photographs of, where we try to do quick tests. We have a module called Quick Test, where we do a 5, 10, or 15 second test, and we try to educate patients while we're there and send them to clinics where they can get the full evaluation done and get their rehab done there as well. So this is the Plantar Pro program. It's something that we strongly believe that we have to work together to make a brighter future when it comes to physiotherapy, podiatry, and diabetology. Now, practice-related benefits of using a device like ours: you can support your diagnosis with objective metrics, reduce error rates. You can help patients better visualize their conditions. Often, patients take it more seriously when they understand the risks involved. You will also see better success rates as a result of this. Also, setting objective recovery goals and monitoring patient progress will automatically motivate them. You can use visualizations. You can use data points to actually set hard goals and set treatment goals and make sure patients get there. By measuring and observing outcomes, you're bound to improve your success rates and you're bound to enhance patient loyalty and reputation as a result of it. And lastly, you can use it as a wide use of as a screening tool to help early detection and also prevent serious injuries. Now, we work with a lot of clients in Bombay. We've initially started selling only early this year, and we work with a lot of clients in Mumbai. And basically, this is their findings within a 2-month usage of the mat. They see increase in success rates already between clinics which have multiple physios. They have seen an increase in revenue by 20% because they've chosen to charge for the test, or they have seen an increase in patients through their corporate programs or through us. or they've also tried to package the test as a part of their entire 3, 6, 9 session packages. They've seen a reduction in dropout rates by 30% almost, which is quite amazing. And this is something that we are very proud of, that patients are taking their treatment more seriously and also completing their sessions. They're seeing an improvement in their brand image. A lot of them have marketed it online as well. And also they've opened up new avenues like recommending and providing customized orthotics as well. Lastly, you have building patient trust, and that becomes a very crucial part of running a physiotherapy practice in today's world. Here are some of the images that we did. We did almost 1,000 quick scans in 2 days with my team in the Mantralaya in Mumbai. We've been in the police marathon. We've worked with amateur footballers in the Roots as part of the Roots Academy, and we've also done the cancer marathon that happened recently in February. Ever since then, we've all been in lockdown, so we're excited. We're eager to get out there as things open up slowly. Lastly, I just want to tell you about what the package includes before I open up to some questions. The OM 3000 plantar pressure mat obviously is the main core component of it. We provide a high resolution Android tablet with it as well that comes fully loaded with the Ezra application on it, and you will constantly get upgrades. A premium travel bag, which is something that helps you take the mat from one location to another, 2 micro USB chargers, one external battery with micro USB and DC outs, 2-year warranty, free recalibration. So free recalibration is something that the mat is calibrated, and it's something that is not going to give you a trouble over the lifetime. But if you ever think that you want it to get recalibrated, I can make sure it gets done, right? And make sure that we can get take advantage of the fact that we are a local company and trying to make sure that we get the best quality out there for the patients. Lastly, training for all personnel is included in this. We train them rigorously. We have exams also set, and we also provide certifications at the end of it. We also provide unlimited access to our online webinars. This is something that is currently under development. It is a first hand due to the lockdown, but it's something that is going to add a lot of value when you have new junior physiotherapists or new physiotherapists joining your clinic time and again. And lastly, you get automatically enrolled as a Plantar Pro partner if you choose to be. Now, this ends my presentation. I have tried to be as quick as I can. I just want to make sure that before I take questions, I would love to answer as many as I can. I am not a physiotherapist. I am I'm the business mind behind this, but I will do my best to answer every question possible. Dr. Himanshu, I'll throw it back to you now.
All right, sir. Thank you so much. That was really wonderful having you here. And so well, you have explained everything right here. So that was really amazing that students or clinicians, all those who have been attending this lecture of yours must have understood a lot about plantar pressure analysis and obviously the instrumentations and working of the pressure plate system. So we have a few questions here, what people want to ask you. So the first question that comes to you is, the person want to ask here is that say in pes planus condition, that is in flat foot condition, the first question is that you want to know which muscle is involved. So I would like to answer this, that it's always that whenever it's a pes planus or a flat foot condition, so there is an associated PTTD syndrome, that is your posterior tibial tendon dysfunction syndrome, which is associated. So the muscle which is involved is posterior tibialis posterior. And what he want to know is that is there any way that we can analyze foot pressure in flat foot conditions? So I think that could be easily explained, and that you have already explained also, that the medial pressure is actually. So if you want to, I want to add on with this something.
So if you're looking at trying to understand, so when you're in a pes planus, which is your in your flat-footed condition, if you're trying to understand whether there is pronation happening and whether there is any basically as someone is walking, how is whether there is pronation happening at the forefoot and the midfoot, you can actually look at that by studying the CPEI, which is the excursion index that is available to you, and it can indicate how the person's gait pattern is, whether the person is supinating or pronating at the forefoot or the midfoot. So that can help in further evaluation.
Okay, great. So we have another question coming up here. That is again a clinical question. I think that has not much to do with the pressure analysis or the pressure plate. So the person want to ask is, if doing the single leg stance, then lift upon, does there is some difficulties with doing that, you can advise what might cause that? Weak calf muscles, or would it be more in the foot? So I would like to add on before you say anything about it.
No, sure, please.
Split system. So Bharti is the one who has asked it. Bharti, I would like to add on that if you mean by the lift upon thing is if it is your heel raise or standing on up on your toes, if it's like that. So if the person is not able to do that, either there can be a glitch in the calf muscle. Usually it is a thing in TA tendinitis or tendon Achilles tear. If it's not the case, if the history is not traumatic, in that case, it definitely can be your static balance or proprioception at the ankle joint and the various other joints of the foot. So now you can add on, Rebecca,
No,
about it.
I think you covered everything about it. I think not being a practitioner, I don't want to delve too much into it, but I think you've covered what I had in mind as well.
So we have another question coming up here is if the patient is a tailor and a patient having a severe plantar fasciitis and patient is obese, so what we can give her advice at home? Any shoe modification? So again, it's a if you want to add on something, you can
Yeah,
add on without.
I think a couple of things I've learned while working with different practitioners is that when you have severe cases like this and the patient is obese at home, one of the recommendations is not to walk barefoot. You can correct me if I'm wrong, Dr. Himanshu. This is something that is mostly your domain, but not to not to walk barefoot, and try to prefer using a slipper with a with cushioning and an arch support of some sort to help redistribute and also minimize the amount of pain. That is the recommendation that I would have given, having learned it from different physios and different practitioners. Please correct me if I'm wrong, and
So
or
that's
if you want to
perfectly
add
right.
anything to it.
That's perfectly right. I would just like to add on. Dhruvi has asked us this. So Dhruvi, it's not like that. Whenever you're having a plantar fasciitis, it's not like that you'll always have
Right.
a plantar pressure change. So if you have a chronic plantar fasciitis, or if the pain quotient of the patient is too much, in that case only the pressure imbalances takes place on the plantar aspect of the foot. So today what we are discussing is the differences that comes in the normal misalignment of the pressure that comes on the plantar surface that could be adjusted by the pressure plate system. So it is not always that the pressure plate system could diagnose with your plantar with your this plantar fasciitis, until unless the patient is going into an antalgic
Mhm.
gait or a gait which is disturbing the normal mechanics of the gait. Okay,
Right.
which is altering the pressure distribution on the plantar surface of the plate of the foot. So
Right.
that is something what we are discussing today, and that is what something the the pressure plate can diagnose. All right, I hope I must be clear about that. Yeah,
Yes.
so it is, it's up to you.
Yes. Oh, yes. So on this particular aspect, I think you're absolutely right. And we've one of the other things that I also want to make sure is that even when you're treating a plantar fasciitis patient, and there are a couple of exercises that you can give for the foot at times, right? Even when you're treating them, one of the things that you have to understand is plantar pressure. Once tissue damage has happened, plantar pressure. When you study plantar pressure, even 3 months later, it is possible that you might see similar patterns once you've been diagnosed with plantar fasciitis, because because of the damaging tissues, the pressure distribution may not have changed. You might still be putting a lot more on the same areas as you were before. Correct, doctor?
Perfect. That's perfect. And I hope so. What we can do here is you can just put your email ID in the comment
Yes.
box, so the chat box, so that the people who are listening to us, the people who will be listening, because this video will be available on YouTube. So if the people want to ask you anything, they can directly come and email you their questions, and you can directly answer their questions on the mail.
Sure. Sure.
Right?
Actually, I would just want to put out one thing there, that if anyone wants to know a little bit more about the plantar pressure system, wants to get it from a physiotherapist perspective, or about our device, you can definitely contact me or Dr. Himanshu as well. We'd be able to, he'll help us connect with each other, and also you can contact me directly as well. Uh, I would be happy to set up a session also with my physio, who can further get into the details of the clinical practice and that nature of
Super,
it.
super.
Yeah.
That will be
So
super.
I don't know how to add comments here. I do have a team member who has been adding and replying
Yeah, so he'll be doing
consistently.
he'll be doing
Uh,
that. That's
Yeah.
he'll be doing that.
So Sunil will be adding an email ID and also a contact number. You please feel free to
Sure.
message us, call us, or email us at any time to know more.
Perfect. So, Hriday sir, so by this we have come to the end of our session of the day. So, what
Yes.
would be the take-home message for the day?
All right. So the
I
message for the
always
day, so no, I think the message for the day for me is that I think physiotherapy is on the brink of great things in India. It requires a more evidence-based practice approach, and that is something that I hope most institutes, most practitioners are going towards. And I recommend everybody, from what I have seen in my own, working with different practices with different physiotherapists, evidence-based practice really work for both your clinical, like for both clinically as well as business-wise, and it's something that we strongly recommend to be taking up. So that's all I can say. That is my message for the day. Not even
amazing.
including my product, evidence-based practice is the way forward.
Great. So that was a wonderful session, sir. We are looking forward to more of such sessions along with you, with more, even if your physio can come and
Oh, most
add some
certainly.
clinical things into it. So that will be a great session, what we can have. So thank you
Most
so much, sir,
certainly.
for sparing out time. That was really a wonderful session, and you answered it so well, the queries of the students and the clinicians. And I am pretty hopeful that they'll be contacting you again for more of
Sure.
such questions and queries, which are coming in their clinical practices. Thank you so
Absolutely.
much. The video will
Thank
be
you very
there.
much.
Everybody can see the whole video again on YouTube. It will be there. The link will be same. Please, everybody who's there, I would request, please like, share, and subscribe the channel, and please spread the video more. Most importantly, thank
Sure.
you so much.
Thank you very much,
We'll,
Doctor.
you're welcome. We'll join back to everybody for our next sessions coming in the future days. Thank you so much.
Thank you.